Alterations in regulation and metabolism, disorders of the endocrine system. Pituitary disorders result from excessive or deficient secretions of pituitary hormones. Hyperpituitarism is caused by an oversecretion of the growth hormone due to hyperplasia. Gigantism will occur when there's an oversecretion of the growth hormone before puberty, and these clients will grow abnormally tall. Acromegaly occurs from an oversecretion of the growth hormone during adulthood. The bones of these clients are going to broaden instead of lengthen. So in other words, with gigantism, the bones grow lengthwise. With acromegaly, the bones are going to grow widthwise. With acromegaly, these clients are going to have coarse features such as a huge lower jaw, thick lips, thickened tongue, bulging forehead, a bulbous nose, large hands and feet, and enlarged organs and muscle weakness. We determine acromegaly by checking levels of the growth hormone, doing a glucose tolerance test in which the growth hormone levels are going to remain elevated instead of lowering as normal. Medically and surgically, we may do a hypophysectomy, which is a surgical removal of the pituitary gland that goes in through the nose and requires monitoring postoperatively for cerebrospinal fluid. We may also do radiation, hormone therapy, and drug therapy. These clients are going to require psychological support. They need to pace their activities to accommodate fatigue, pain relief, encourage self-care. Postoperative care, once again, we need to monitor not only for the cerebrospinal fluid, but because it's a brain surgery, we need to monitor for increased intracranial pressure. An insufficient secretion of the growth hormone during childhood will result in dwarfism. Panhypopituitarism is an absence of the pituitary hormonal activity that results in Simmons disease. With Simmons disease, the anterior pituitary hormone activity will stop. These clients may experience hypothyroidism, hypoglycemia, adrenal insufficiency, gonad and genitalia atrophy, premature aging, cachexia, or physical wasting. We are going to substitute hormones, and Simmons disease is fatal if it's not treated. So nurses need to teach adherence of the medication schedule, monitor the blood hormone level, and eat small, frequent meals. Diabetes insipidus is a disorder in which the body will excrete extremely large amounts of urine. It's caused by too little antidiuretic hormone, an inability to respond to the antidiuretic hormone, or head trauma, including brain tumors or a hypophysectomy. These clients will experience polyuria up to 20 liters in a 24-hour period, weight loss, constant thirst, weakness, and dehydration. We diagnose through a fluid deprivation test, urine-specific gravity, which measures concentration of the urine, and that will be almost equal to water. Serum osmolality will be elevated because of the dehydration. We treat it with drug therapy, IV fluids, and sometimes a diazide or a thiazide diuretic. Nurses need to monitor the fluid intake and output, daily weight, and encourage an appropriate fluid intake, in addition to monitoring IV fluids. The syndrome of inappropriate antidiuretic hormone is the reabsorption of the body's water instead of excreting it. It's caused by lung and brain tumors, a central nervous system disorder, head trauma, and some drugs. These clients are going to have water retention, hyponatremia due to dilution, headaches, muscle cramps, anorexia, and changes in the level of consciousness. We diagnose through urine levels. Serum sodium and osmolarity levels are going to be decreased, while the urine sodium and osmolarity levels are going to be elevated. We need to treat the underlying cause, and this may require osmotic and loop diuretics and IV administration of sodium chloride. Nurses need to, once again, monitor fluid intake and output and vital signs, assess for changes in level of consciousness and fluid overload in addition to hyponatremia, and stress the importance of adhering to those medication regimens. So, is the following statement true or false? Acromegaly is caused by an oversecretion of the growth hormone before puberty. This is going to be false because it's caused by oversecretion of that growth hormone during adulthood. Again, true or false? A sign of panhypopituitarism is premature aging, and this is true. So the thyroid gland regulates body metabolism. Thyroid disorders can escape detection until they're severe because those symptoms are so vague. Treatment can be long-term, and it can take several weeks to be effective following initiation, and then it will require follow-up to monitor that response. So a lot of these clients are going to get discouraged once they start a medication treatment because they think things are not working, and then they need to be educated that it's going to take several weeks before they start seeing any changes. So with hyperthyroidism, we see Graves' disease. This is a hypersecretion of the thyroid hormones, potentially from an autoimmune or genetic traits. These clients will have increased metabolic rates. They'll be restless, agitated, have hand tremors, diarrhea, increased appetite, weight loss, exophthalmos, neck swelling, tachycardia, hypertension, and warm, moist skin. These clients are going to have an elevated serum T3, T4, and a decreased TSH. And we use the thyroid scan and ultrasonography in addition to blood work to diagnose. We treat with antithyroid drugs, radiation, thyroidectomy, in which antithyroid medications will be administered prior to surgery, because when they begin to manipulate that thyroid gland with surgery, we don't want to have a dramatic release of that hormone. Gerontological considerations: the older adult can exhibit atypical symptoms or minor symptoms, and they may be considered to be normal aging changes. And they may also have an increased incidence of nodules and small goiters. Nurses need to remember that forceful palpation of the thyroid can also release high levels of thyroid hormone. We need to monitor the vital signs and monitor for hypocalcemia, in addition to encouraging rest and a high-calorie diet. A thyrotoxic crisis is also known as a thyroid storm or thyrotoxicosis. This is an abrupt, life-threatening form of hyperthyroidism that's triggered by stress, infection, diabetic ketoacidosis, trauma, and toxemia with pregnancy, or palpation of a hyperactive thyroid. These clients will have, in addition to all of the hyperthyroid symptoms, a high temperature, increased rapid pulse, dyspnea, cardiac dysrhythmias, vomiting, and delirium. We will look at their hyperthyroidism history, and these clients will also have a markedly elevated serum T3 and T4. We will need to administer immediate treatment with antithyroid drugs and IV sodium iodide. Nurses need to provide supportive therapy to help decrease those symptoms. Hypothyroidism is a failure of the thyroid glands to secrete sufficient hormones. We see a slowing of the metabolic rate. A severe form of hypothyroidism will be myxedema, and this can lead to a myxedema crisis or coma. These clients will experience the opposite of hyperthyroidism. So instead of being fast, everything's going to slow down. They will exhibit lethargy, weight gain, dry skin, menstrual disorders, an enlarged heart, atherosclerosis, anemia, and a cool, dry skin. They will have an elevated serum TSH, and the FT4 is going to be decreased with a decreased radioactive iodine uptake. We need to treat them with thyroid replacement therapy. Once again, they need to understand that treatment may not happen right away, or relief from the symptoms with treatment may not happen right away. Gerontologically, these symptoms can also resemble normal aging changes. Nurses need to monitor and educate the client that thyroid replacement can cause hyperthyroid symptoms. So these clients need to be educated on symptoms of a hyperthyroid. They also need to have a low-calorie, high-fiber diet until their thyroid level is appropriate. Their diet should also be low sodium, low fat, and low cholesterol in the event of cardiovascular complications. Thyroid tumors are follicular adenoma benign tumors or a papillary carcinoma malignant tumor. These clients will have a nodular thyroid that enlarges, causing neck swelling. Symptoms of hyperthyroidism may occur if the tumor is benign. These clients may also experience hoarseness, difficulty swallowing if malignant. We need to do a biopsy to confirm the diagnosis, and sometimes there's no treatment if the tumor is benign unless it enlarges too much. A thyroidectomy, hormone replacement therapy, and radiation may also be ordered if the tumor is too large or malignant. Nurses provide emotional support and supportive care. The endemic and multinodular goiters are basically enlarged thyroid glands. An endemic goiter is going to be caused by an iodine deficiency, while a non-toxic goiter is caused by excessive goitrogenic foods, and a nodular goiter is going to be caused by iodine deficiency. These clients will have the enlarged thyroid gland, difficulty swallowing or breathing, and we need to treat them by encouraging foods that are high in iodine, administration of potassium iodide, or doing a thyroidectomy. Nurses should monitor for and relieve respiratory symptoms, encourage a diet that's high in iodine, and maybe a soft diet. And thyroiditis is an inflammation of the thyroid gland. It may be acute, which is most common in children from a bacterial infection, or subacute, which follows an upper respiratory viral infection. Hashimoto's is a chronic autoimmune disorder. These clients may experience that high fever, malaise, swollen tender thyroid gland, or hyperthyroid symptoms. We diagnose with a thyroid scan. These clients may also have elevated white blood cells and elevated thyroid function tests. We treat with antibiotics, analgesics, corticosteroids, a thyroid hormone replacement therapy, or surgery. Nurses provide supportive care to help manage those symptoms and encourage following that medication regimen. So, true or false? The etiology of Graves' disease is going to be the hyposecretion of thyroid hormones. And of course, this is false. That's the oversecretion. So the parathyroid gland maintains serum calcium and phosphorus levels. Hyperparathyroidism is going to be an excess of the parathormone. It may be a primary or secondary condition. With primary, we see an adenoma, an increased secretion of that parathormone, which removes calcium from the bone, and it causes bone demineralization and kidney stones. Secondary would be due to an increased secretion in response to the hypocalcemia. These clients will experience fatigue, hypotonic muscles, skeletal tenderness and pain, and cardiac dysrhythmias. We diagnose through an elevated serum and urine calcium level, an MRI, and a CT scan. These clients should be placed on a calcium-restricted diet, may receive sodium and phosphorus replacements, or surgery. Nurses should monitor the intake and output for urinary calculi and safe environment to help prevent falls, encourage fluid intake, and postoperatively provide client education in addition to the effects of the disease and adherence to treatment. Hypoparathyroidism would be the deficiency that results in hypocalcemia. It is a deficiency of the parathormone due to trauma to the glands, and we may also see hypocalcemia. These clients have neuromuscular hyperexcitability, tetany, a positive Costik's intruso signs, laryngeal spasms with dyspnea. We diagnose through decreased serum calcium and elevated phosphorus levels and x-rays. We treat it with IV calcium salts, endotracheal intubation, mechanical ventilation, oral calcium, and a diet high in calcium and low in phosphorus. Nurses monitor for signs of tetany and muscle spasms. They monitor IV site carefully with IV calcium salts and assist with those ADLs and decreased stimulation while stressing the importance of drug and diet therapy. The adrenal glands are going to secrete mineralocorticoids, glucocorticoids, and gonatocorticoids, all known as the corticosteroids, in addition to the catecholamines, epinephrine, and norepinephrine. Adrenal insufficiency would be an inadequate production of corticosteroids, such as Addison's disease. Primary or Addison's disease is going to be the destruction of adrenal cortex from diseases, or it may be an autoimmune disorder that results in hypoglycemia. Secondary is going to be the result of a surgical removal, hemorrhagic infarction, hypopituitarism, medications. The client doesn't have to experience adrenal insufficiency symptoms due to those steroid replacements. These clients will have hypoglycemia, a dark pigmentation, personality changes, anorexia, vascular collapse, or gastrointestinal symptoms. We diagnose through a decreased serum cortisol, sodium, and glucose levels. We have elevated white blood cells, potassium, calcium, and BUN. We also will look at radiographs and a CT scan. We treat it through a daily lifelong corticosteroid replacement therapy. Nurses need to encourage these clients not to omit or change doses. They should avoid infection or fatigue and wear that Medic Alert bracelet or necklace. They should have a high sodium and protein, moderate carbohydrate diet with frequent meals and snacks. An acute adrenal crisis is going to be a life-threatening emergency. These clients have abnormal stress, trauma, salt deprivation, or a sudden cessation of corticosteroid therapy. They will experience anorexia, vomiting, diarrhea, abdominal pain, hypotension, or fever. We diagnose by looking at their gastrointestinal symptoms, profound weakness, headache, increased hypotension, restlessness, or fever. We're going to treat it with corticosteroids, glucose, and/or antibiotics. Nurses need to recognize and monitor for adrenal crises, monitor vital signs, and provide client education on the importance of adhering to the medication regimen. A pheochromocytoma is a tumor of the adrenal medulla that causes hyperfunction. It comes from a benign tumor that causes excessive catecholamine secretion. Remember, that's epinephrine and norepinephrine. These clients are going to have an elevated blood pressure, tremors, hyperglycemia, polyuria, vertigo, headache, or nausea and vomiting. We diagnose through a 24-hour urine, CT scan, MRI, ultrasonography, or retrograde pylography. We treat it with a unilateral adrenalectomy, meaning we just remove one, or drug therapy. Nurses should monitor the blood pressure or signs of an acute adrenal insufficiency. Cushing's syndrome is an excessive secretion of adrenal hormones caused by an excessive ACTH, tumors, or prolonged corticosteroid administration. These clients will begin to experience the Cushingoid syndrome, where they have the physical changes such as muscle wasting, symptoms of diabetes mellitus, the moon face, that buffalo hump, an increased susceptibility to wounds and slowed wound healing. They'll also have easy bruising, masculinization in women, and develop kyphosis. These clients are diagnosed through an elevated urine and plasma cortisol level, dexamethasone suppression test, 24-hour urine, blood test, X-rays, an IV pyelogram, CT scan, or MRI. Treatment will be dependent on the cause, and it may include radiation, drug therapy, or surgery. Nurses should encourage never abruptly stopping the corticosteroid therapy because it can induce that adrenal crisis. Hyperaldosteronism is the excessive excretion of aldosterone. It comes from a benign aldosterone secreting adenoma, malignant tumor, or the cause may be unknown. These clients will experience muscle weakness, fatigue, cardiac dysrhythmias, headache, increased urine, and hypertension. We diagnose by looking at the serum sodium, which will be decreased, and we'll have an increased serum potassium. Also with CT scan, MRI, or an adrenal venography. We treat it by doing that unilateral adrenalectomy, once again just removing one, drug therapy, and diet therapy. Nurses should monitor vital signs and monitor for hypernatremia and hypokalemia, and do routine weights. An adrenalectomy will be the removal of an adrenal gland through a laparoscopic or a large open incision. Nurses preoperatively need to provide that preoperative education, bed rest, and of course monitor the blood pressure. Postoperatively is going to be the usual postoperative care, in addition to monitoring for signs of adrenal insufficiency, which would require immediate physician notification.